Good evening, gentle listener, and welcome to The Interview, a Human Body Systems production, with your host, Curious Christian, and his guest, the dandy, distinguished, and dashingly handsome Dr. Jake Rockman. This evening, the dynamic duo discuss all deranged subjects about ophthalmology. From crazy contraptions to carefully chalked out career plans, they will cover it all. Yes, it's time for The Journey and Life of an Eye Doctor. Please prepare to put on your glasses and enjoy the show. Okay, I'm Christian Vetrano. I'm here with Dr. Rockman, my eye doctor, and we're just gonna start right into it and talk about this interview.
Sounds
okay?
great.
So first of all, what is your profession?
I'm an optometrist. I'm as we call it, doctor of optometry.
Okay.
Yep.
And because later in life I'm thinking about going into your profession, I was wondering what college you went to and how long it took you to
Sure.
to be.
Absolutely. So for undergraduate school, I went to Florida International University, and for graduate school, I went to Nova Southeastern University, which is actually the only optometry school in the state of Florida.
Yep. Tell me the kind of characteristics you have to take in order to be in your profession.
Absolutely. So from an academic standpoint, it's very tedious work because it's a lot of sciences. It's a lot of calculus, biology, chemistry, organic chemistry, physics. So it's very rigorous from that standpoint. So mentally very challenging. So very you need a lot of mental stamina to kind of get through that. A lot of discipline from a studying standpoint. As far as optometry school is concerned, it's nothing harder that you would do in undergraduate school, but the difference between undergraduate and graduate school is the volume of work, meaning the amount of credits. So when I was in college, I took maybe 12 to 15 credits per semester, 15 on the higher side. When you're in optometry school, you're taking about 21 to 25 credits per semester. So learning how to balance your life, right, and your study habits and all that is essential. So organization is important. As far as from a career standpoint, being personable is important in this career. There's some that are essential, some that are not. I think it really just depends because you get some doctors that are a little bit drier than others. So I think it's really a preference thing.
Absolutely. I understand that you had a career change
I
halfway
did.
through, and
I did.
And you went from entrepreneurship into optometry, correct?
I did. So, go ahead.
And I was just wondering if you could explain your transition and how, and if at all, entrepreneurship can relate to what you do now.
Absolutely. So they definitely go hand in hand. When I was in undergraduate school, I was a finance major. So I was about a semester shy, so we'll say about 12 credits shy of graduating with a finance degree. When the time came to leave college and exit the real world, I was looking at jobs and I said, well, what am I really going to do? Am I going to go into wealth management, sales? And I realized that it wasn't what I wanted to do. So I'm kind of a unique case. Most people that go into optometry school have some kind of biology degree, have a degree in biology, chemistry, in the science field. I didn't have any of those credits. I had the general credits, but I didn't have any of the sciences. So I had to go back and take all my prerequisites, my trigonometry, calculus 1, calculus 2, bio 1, bio 2, chem 1, chem 2, organic chemistry, physics 1, physics 2. And from a technical standpoint, you can apply and get into optometry school if you have 120 credits or more, along with the prerequisites that are required for entrance. So that's what I did. So technically, when I left undergraduate school, I did not have a bachelor's degree, but I had about 170 credits, part business, finance, part science.
So that definitely made quite a difference in time that you were able to show.
It did indeed. So it dragged out my undergraduate typically from a 4-year to about 5.5 years. I was able to knock out all those science credits in a 1.5 years, but I took about 15 to 18 credits a semester, which is a lot.
Yeah.
As far as transition into the real world, in the business world, having that background allowed me to be not only a doctor, but a doctor and a businessman, right? It kind of gave me the business background to not only excel as a doctor, but to understand the business component of it, because there is a business side to being a doctor.
Yeah.
A lot of doctors are really good doctors, but they're really poor businessmen, right? So you kind of need both to go hand in hand, but I should say you don't need both. But if you can have both, that would be better.
Awesome. So in school we learned about the anatomy of the eye and how the eye works, something we can see. However, we didn't really go into how a doctor is able to measure the prescription of an eye to help us see. So if you could go through what you have to do in order to get a prescription of somebody, that would be great.
Absolutely. So just to kind of touch on the anatomy, the eye is kind of like a camera. Okay, we have a lens on the front of the eye, which is the cornea. It reflects light, and then we have the lens on the inside of the eye. Okay, breaking it down to a layman term, it all comes down to physics. It's optics, the way a lens works and where it focuses light. So some people's eye is out of focus, and what these instruments do is we use lenses to put in front of the eye to essentially readjust that light and focus that light on the retina so we can see. Okay, somebody who's nearsighted, okay, sees good up close, bad far away. We have to bring that light back to put it onto the retina. This is getting really technical, but essentially what we're doing is it's kind of like adjusting a camera. So we're adjusting that camera by using lenses, but to put that image in focus for that person to see.
I see.
This contraption here allows me to manipulate a series of lenses to essentially correct your vision and provide you with distance vision.
Oh, okay. So when I have those letters up on the screen, then you're able to change the lenses to see if I'm able to see the letters.
Exactly, according to the optics of your eye. So what we do is we have really fancy technology that goes in and we shoot a laser into the eye. We take an initial scan, and that initial laser shoots a laser in and it measures what we call the refractive error of your eye. So that kind of tells me how out of focus is your eye.
I see.
Okay. I then use these lenses which correspond with the particular power, kind of like a magnifier, like a handheld magnifier. Okay, and I adjust these lenses according to the power of your eye to match up to bring things in focus for you.
So do you think with technology advancing almost every day, that a job like an eye doctor or an eye surgeon could be replaced by AI eventually?
Absolutely. So it's already being replaced to an extent. As far as the in-person interaction, patients do like that, but from a refractive standpoint, there are technologies to where doctors are performing examinations remotely through a computer screen and a camera. It doesn't really account for the assessing the health of the eyes, right, without any kind of photos or anything like that. But it is in current practice, and it's one of those things to where eventually it could happen. Do I think it will happen? Probably not. But I do think that they can be incorporated into practice and kind of have a symbiotic relationship to where it can be beneficial for the doctor and the patient. So yeah, so they kind of go hand in hand. They can both work very well together. We can use telemedicine in many aspects of primary care physicians. A lot of primary care doctors use photos like these here to assess diabetic retinopathy. Ideally, the eye doctor is better trained to identify that, but telemedicine is a emerging technology, and it is here to stay. The question is, will it fully replace the brick and mortar establishment? To be determined. I don't think so. However, as an eye doctor, we have to physically look at the eyes and assess them, especially the anterior segment, the front of the eye, and that's not something that we can do through a camera or not in person.
Yeah, and then when it comes to a surgeon point of view, you don't think like a machine could just do everything that the doctor could? Do you think there's certain aspects that the doctor has to have?
Absolutely. So that's a great question. There are robotics, so there is robotic surgery currently being performed. However, we still have to have a doctor to control those robotics. So, you know, at some point in the future, might there be technology and AI that can completely do surgery? I'm sure there will be, but I think you always have to have that human factor incorporated in it as well. From a surgeon standpoint, nowadays, we have to physically go into the eye manually. It's very sensitive, very sensitive, very delicate surgery. So from an eye standpoint, I don't think that will ever happen, but things are evolving so quickly and so rapidly that it's very possible it could happen.
Of course. Now, if we take a look at the picture of my eye here, can you describe what this picture of my eye might tell you, and what we would see in a different unhealthy eye, like to the right?
Absolutely. So the eye is kind of like the window to the health of the body. So there's a lot of different things that manifest itself systemically. A lot of different diseases: diabetes, high blood pressure, from infectious stuff, tuberculosis to syphilis, to colon cancer, things like that. This here is a picture of your eye, okay, and this is the back of the eye here. So this is what we call your optic nerve here. This is a pretty cool technology in the sense that it allows me to see the back of the eye. So kind of touching back to that AI that we were discussing before, this machine here allows me to kind of zoom in. Normally when we dilate your eye, right, in person, we would put a drop in, it would open up the pupil, allows me to see into the eye. This is a pretty cool technology. It allows me to zoom in, and what it does is it gives me a 360 picture of the back of the eye,
Wow.
right? So now kind of zooming back out and closing this out, it takes that 3D picture and it puts it into a 2D flat map here. So looking at this here, just a little eye anatomy, this is your optic nerve here. Okay, that's kind of like the Comcast cable that connects that eye to the brain.
Yeah.
Okay, this is your macula, and then you see all these blood vessels here. So your eye is perfectly healthy. There's a lot of things that can manifest itself, like we said, in the eye is diabetes, right? So when you have diabetes, these blood vessels become leaky and they leak blood into the retina. Diabetes is the leading cause of blindness in the United States.
Wow. I
Mhm.
did not know that.
When we have hypertension, right, these blood vessels become very what we call attenuated, okay? And we see that effects in the eyes. We can have bleeding, things like that, secondary to high blood pressure. There's a lot of different things that show itself in the eye. The list is extensive. Almost every systemic disease has some type of eye manifestation. Will it get to the extent to where it will manifest itself in the eye? Not necessarily always the case, but usually we see some form of it. If you look at this photo over here, you would look at this and say, wow, that doesn't look normal. You would see all these spots here. So this is what we call chirpy. And this is just a sample photo, but this is what we call chirpy. Chirpy is a type of change in the retina that's been associated with what we call FAP, in layman's terms, polyps, eventually colon cancer. Okay, so when we see this particular pattern, we know that we want to do a colonoscopy and make sure there's nothing going on from a GI standpoint.
Oh, so that's very interesting. You're able to look at the eye and be able to correlate that to other systems in your body,
Correct.
and possibly deter a possible illness in the future.
That is correct. Well, this could be an illness in the future or a present illness. So, for example, rheumatoid arthritis, Sjogren's disease. There are so many. The list can go on, but every disease can kind of manifest itself in the eyes in some shape or form.
I see. Very cool.
Yes. This here, Christian, is what we call a tear. So you've heard of a retinal tear, retinal detachment before.
Yes.
Okay. So the eye kind of being a sphere. Okay. It's basically lined with a tissue paper thin, with a piece of tissue that's basically tissue paper thin. Okay.
Yeah.
And that's what we call the retina, and that's what allows us to see. Okay. This here would be a break in the retina. So if you look at this little delineation right here, this is that little piece of tissue, right, that's been torn, and that's what we call a horseshoe tear. When this goes untreated, what happens is fluid builds up underneath this tissue, and it pulls away. And that causes a retinal detachment, which leads to blindness if it's not repaired. How do we treat a horseshoe tear in this situation is we would take some laser, and basically we would take a laser and we would seal it down. So when we take a laser, what it does is it goes in here and it creates a scar. And what does that scar do? Is that scar binds that tissue, the superficial, to the bottom one.
Oh, I see.
Mm-hmm.
Okay.
So what it does is it prevents that retina from pulling away in the rest of the eye. So it almost creates like a barrier, like a scarring barrier, which holds that retina in place.
Does that show in your vision if you were to have a tear? If you had a scar there, would
That's
that
a
show?
great question. So you wouldn't necessarily see the scar, but the signs and symptoms of this horseshoe tear or retinal detachment can manifest itself in your vision as flashes, floaters, anything like that.
And what exactly is a flash? Is it just like a flash of light, a flash of darkness? Or?
Great question. So that would be almost as if someone took a picture off to the side, a lightning bolt camera flash. You know, if you're,
Okay.
floaters in your vision, black spots. Eventually, when it gets to retinal detachment, that can almost appear as a curtain coming down over your vision. Sometimes black, sometimes see-through, depending on the extent of it. But definitely not something that you want, or something that left untreated will cause blindness in the eye.
Yeah. What would cause a tear like that?
That's a great question. So sometimes just being highly myopic, in layman's terms, being highly nearsighted, and the reason why that would cause a tear is because the eye tends to be more elongated. Okay, when the eye is more elongated, what does that mean? That means that retina is a little bit thinner in the peripheral portion. So if you had a room that's 10 by 10 square feet and only 9 by 9 square feet of carpet, how do you get that carpet to fit? The retina being the carpet, the room being the eye, you have to stretch that retina. When that retina gets stretched, it's more prone to ripping and tearing. People who are highly myopic, more nearsighted, have a higher propensity to developing a tear or detachment.
And as for the
Just to
picture-
kind of, sorry to interrupt you,
no,
just to
no.
kind of add to that question, there's also other things that could cause it. Trauma to the eye. Sometimes just as we get older, the aging process, that retina pulls away or tears. So a number of different factors that could lead to this here, but ultimately the highest prevalence being people who are really nearsighted or people who have some kind of acute trauma.
And to the picture to the right, are
Yes.
you able to see what would your vision be like if you had?
This person would actually have normal vision. This person would probably not know that they can have this in their eye. This is actually just a benign finding. This is what we call retinal hypoplasia, meaning abundance of growth. Think of as hypoplasia more. I don't know how to explain this in a layman term, but just abundance of cell growth, benign.
Okay.
So this here, these lesions here are in a layer that is below the retina. Think of it like that. Okay, the retina sits on top of this here. You see how this here, see these blood vessels go on top of that mark?
Yes.
You see that? Meaning that that black spot is deeper, is behind it. Exactly.
Okay.
Exactly.
And going back to the picture on the left,
Sure.
you said a way to fix that would be scarring. But what if it's too late and it's pretty already?
Yeah, so typically step one, this would be what we call a horseshoe tear. Okay, without this hasn't turned into what we call a retinal detachment, where that retina in entirety has pulled off. Okay, at this point, this would require a laser treatment. Now, if it subsequently had led to a retinal detachment, what is the surgery for that? There's a number of different surgeries, and it really depends on the circumstances and the extent of the detachment. But sometimes what can indicate what we call a scleral buckle, to where they go in to reattach it. Sometimes they go in and what they do is they put a gas bubble, right? So think of it as the eye being a sphere, and that retina kind of falling off like this here. It's detached from this part of the eye falling off. So how do they get that retina to reattach? What they can do is sometimes they can go in and put a gas bubble in, and what does that gas bubble do is it pushes this retina back on to the back of the eye, and then at that point they would take a laser and do some laser around it and scar that retina back into place.
Oh, that's really interesting.
Yes.
And when it comes to surgery outside of that, if you had some problem, like you wanted to get laser eye surgery or something, would that be a problem future or?
For some kind of, did you say for LASIK surgery?
Yeah.
Yeah. So it could be, it would be a contraindication sometimes.
Okay.
And it also depends on the extent of it, the vision after the surgery. If you had a horseshoe tear out here, it's really not going to affect your central vision, right?
Yeah.
If that retina completely detaches, then there's not going to be a whole lot of function in the eye left. However, if you have a retinal tear out here, this is what we call the peripheral retina. We get our central vision from this tiny little black spot right here. And I'm going to go to your eye because it's a little bit easier to see. But if you kind of look at this big photo and you look at this gray spot right here, this tiny little area right here provides us all of our central vision. So you might have heard of macular degeneration.
I have, yeah.
So somebody who has macular degeneration, typically age-related, right, has deterioration of this tiny little area. What does that mean? That means they can't use their central vision to see. Typically, we get all of our acuity from this central vision here, from that tiny little spot there.
So when I look, like, if I were to look into the sun, would that be darker? Would that show anything, or?
Yeah, absolutely, and that happens all the time. People stare at the sun, and that causes what we call solar retinopathy. And what that does is that damages this retina, a deeper layer of this retina, and it's hard to explain what you would see to an untrained eye, but essentially you would see almost like a little red spot, a little darker red spot right here. If we were to take another particular type of scan of the eye, you would see that there's a segment that's missing, that's damaged. So quite often, people stare at the sun and they lose vision. They don't go completely blind, but they damage the macula, which provides them their central vision, which in turn affects their overall acuity.
So it wouldn't like make like a dark spot in the eye. Instead, it would just lessen the effectiveness of
When you
seeing
say a
something?
dark spot, what do you mean?
Like if you had like a black hole in the middle of your vision or something.
It would kind of cause, it wouldn't necessarily cause, it could cause a black spot, I guess you would say a scotoma would be the perfect term, kind of thing. Sometimes it manifests itself as a scotoma, sometimes it manifests itself as just not being able to see. So it clinically, subjectively a little bit different depending on the extent and how deep that damage is into the retina.
Okay.
Yes.
Thank you.
Yeah, great question.
So, tell me a little bit about the anatomy of the eye and how light can go through and basically make the objects that we can see.
Absolutely, that's a great question. So this here would be a cross section of the eye here. So kind of zooming in a little bit, we have what we call the cornea here. So think of the eye as kind of as a camera, right? We have lens number 1 right here, which is what we call the cornea, okay? Right behind the cornea, we have what's called the anterior chamber, and this is filled with a little pocket of fluid, okay? This fluid is produced by this little piece of tissue right here. It kind of migrates forward to the front of the eye, and it drains in here back into the back of the eye. Okay, so this is kind of the front of the eye. Okay, now kind of moving a little bit further back, we have the lens in the eye, and this is the big part that refracts light. So we have these two lens number 1, lens number 2. It kind of just grossly speaking, the retina, which is the film of the camera. Now this lens here is part of the eye where it refracts light. Now you've heard of cataracts,
Yes.
right? So this is where somebody would get a cataract. Okay, when we do cataract surgery, what we would do is we would make a small incision here. We would go in, we would suck out this lens, and we would put an implant. What is a cataract, right? So this little lens is made up of little crystalline proteins. When we're young, they're nice and clear, and as we get older, those proteins, they die and they become hazy, almost a yellowish, kind of like a dirty windshield. The better analogy would be almost like a yellow headlight on a car. Okay, when that becomes hazy and clouded, we have trouble seeing out. Okay, typically that's age-related. Okay. There are external factors and systemic factors that can expedite cataract formation. The biggest environmental one being UV light from the sun, which is why it's imperative to wear sunglasses when we're outside. Oh. UV light expedites cataract formation, which impairs your vision. Diabetes, right, is another one that expedites cataract formation. There's a lot of different things. Steroids, right, those would be the big 3, right, that we have control over that would cause premature cataracts, as we would say. Okay, kind of moving in here, we have this is what we call the vitreous humor. So this sphere, the eye being a sphere, is filled with what was called the vitreous humor, which is almost like a jelly-like substance. And what does that do? That insulates the eye, and that provides nutrients to the retina. Okay, kind of zooming in here, you can kind of see this little fin here. They've kind of taken this here and taken a little cross section and kind of dialing it back to what we were talking about before. This little piece of tissue right here is the retina. This is how thin it would be with respect to the other outer part of the eye. So we're talking tissue paper thin. Now, kind of going back a little bit further, this retina encompasses the entire lining of the eye. Okay, you asked me earlier about tears and detachments. That's where this piece of tissue would pull off and pull away from the eye. Right? How do we treat a retina detachment? We would take that laser, go back and seal it, almost like we would weld it down, right? And it stays in place. Yeah. Okay. Now, kind of going back, this is that optic nerve. So when you were looking at that little yellow dot before, what you were seeing was the front side of this here. Okay, so if we turn the eye this way and we look down here, you would see that little circle, right? This here is essentially an extension of the brain. Okay, when someone has glaucoma, right, this optic nerve is damaged. Typically in glaucoma, what happens is the pressure in the eye is high, and what it does is that pressure applies that increased pressure in here. Puts pressure on the nerve, and what it does is it kills those tissues, and it causes this nerve tissue to thin. And when it thins, we lose vision from the outside in. That would be glaucoma. Okay, kind of going back to optics now, because you touched on the optics. How does the eye see? Yeah. Okay, so what happens is light comes in. Okay, somebody who has a perfect eye, right? This light and getting a little deeper, a little bit more complex, right? Physics, right? How does the light when it enters the eye, how does it focus, right?
Yeah.
So we talk about rays. I don't know if you've taken physics or not, but from a refractive component, this eye can either bend light to fall in front of the eye or behind the eye. Touching back on what do those lenses do, right? Lenses either bring the light out and diverge it, or they converge it. But the goal of a lens is to focus this light onto the retina, specifically that area called the macula. So when we put a pair of glasses in front of somebody, what we're doing is we're trying to bend the light to get it to focus exactly on the retina.
You've been in this profession for quite a while, right?
Correct, yes. 9 years.
9 years. And you'd say throughout your time you've had some pros and cons of the job, right?
Absolutely. Some of the pros, some of the cons. For me, the pros definitely outweigh the cons. Some of the pros are I get to help people see, and it's very rewarding. The sense of sight is, I think, one of our most valued senses, and being able to give somebody sight is so rewarding, especially children, adults, everybody. Another pro is that as an eye doctor, we don't have to deal with the blood and guts. It's great for me. I don't prefer that. Also, as an optometrist, there's different scopes which you can practice. You can work side by side with an ophthalmologist and co-manage surgery. You can manage glaucoma, diabetes, all that stuff there, and practice what we would call medical optometry. Or you can choose to work in almost what we call a retail setting, to where you're basically doing glasses, contacts, a lot of the routine care, to where if you were to see some kind of pathology at that point, you would refer it out. If you choose not to manage it, to somebody who does the medical management of any kind of ocular condition. As far as the cons, like I said, for me, there's not a whole lot. But another pro is like going back, kind of touching back on scope. It's usually a 9 to 5 job, right? You can, like I said, you can choose to work side by side with a surgeon. You can choose to work in a hospital. You work in a hospital, you're going to be on call. You work in a private practice, your hours are going to be from 9 to 5. So I think, you really have the option to choose which route you would like to go, which is great.
But you wouldn't say there's many cons in what you're doing?
I think it really depends on what you want to do. If you want to be a surgeon and you want to be in the mix and doing that kind of stuff, then, optometry is not as exciting as surgery and the blood and guts and the emergency stuff. But, no, I would say it's definitely, for me, definitely not a whole lot of cons to it in that sense.
Okay, and continuing with this topic, I heard that you recently became a father, right?
I did, yes, thank you.
And her name's Julia, right?
Indeed, yes.
Would you say that now that you have a really flourishing family, that it's hard to balance your work and your family life?
Sure. Having a newborn is always difficult, balancing, that with work and with the regular life. But for me, it hasn't been much of an issue. As an eye doctor, like I said, we have pretty routine hours, 9 to 5, 8 to 5. Sometimes you can dictate your own hours depending on the scope of practice that you're in. If you own your own business, you can choose to come in and leave as you please. So for me, I'm usually in the office at about 9 o'clock, and I usually leave about 5. So for me, I get home at a reasonable time, and I get to spend adequate time with my family for the rest of the evening, night.
And that must be very rewarding.
Very rewarding, very rewarding. I have friends that work in a hospital setting, and like I said, they're on call. They don't get out till 7 o'clock, 8 o'clock. It really, like I said, just depends on your scope. And as an OD, as an optometrist, you get to dictate what scope of practice you choose to work in, because they're not essentially all the same.
Mm-hmm. Well, thank you very much for
You're welcome,
this
Christian.
interview. It means
My
a lot.
pleasure. You're welcome. Thank you. Absolutely.